Hello, everyone. I'd like to thank those that have joined to listen in on the presentations this afternoon. I'm happy to have the opportunity to talk about an analysis of nutritional status and oral Veillonella in caries-free and caries-affected preschool children in Manitoba. So early childhood caries, or ECC, defined as dental decay affecting the primary dentition of children under 72 months of age, is a widespread multifactorial disease. Dental decay is caused by bacteria present in oral biofilms or dental plaque. These bacteria metabolize dietary fermentable carbohydrates and release acidic byproducts that cause local pH values to fall. Drops in pH results in the demineralization or destruction of tooth tissues. Demineralization is normally paired with remineralization, which can repair and strengthen damaged tissues. However, prolonged exposure to acidic environments can lead to an imbalance in demineralization and cavitation. Many children are disproportionately affected by severe ECC. Children with severe ECC often have irreversible damage to their teeth that requires rehabilitative dental surgery under general anesthesia. Pain, tooth loss, and diminished oral health-related quality of life provides great incentive for treatment and prevention. As ECC is a multifactorial disease, it is dependent on a number of biological, behavioral, and social risk factors. Nutrition is a key determinant of ECC. Metabolically active bacteria in oral biofilms require sugars to function and grow, and these often come from the diet. Development of ECC can depend on the type, form, quantity, and frequency of sugar consumption. High and frequent consumption of sugars has been shown to promote dental decay. High numbers of snacks and total daily eating events have also been shown to increase caries risk. It is important to establish healthy dietary habits early on in a child's life, as they can dictate future behaviors and outcomes. Poverty, parent or caregiver education, and social status can prevent children from experiencing proper nutrition. The role of acidogenic species in the development of dental caries has been well documented. This isn't surprising, as bacterial acids nurture cariogenic environments. Streptococcus mutans is one of the most common lactic acid producing bacteria implicated in dental decay. Elevated levels of Streptococcus parasanguinus, salivarius, sabrinus, and vestibularis have also been linked to dental caries. Streptococcal antagonism or bacterial interference can occur in oral biofilms. For example, Streptococcus gordoni and sanguinis produces hydrogen peroxide that inhibits Streptococcus mutans, and Streptococcus salivarius is a producer of alkali. Secondary microorganisms in the disease process have not been researched as intensely. This includes Veillonella, which can indirectly influence dental decay. Veillonella bacteria are a normal part of the oral flora, but are also associated with periodontal diseases and dental caries. Veillonella atypica, denticariosi, dispar, parvula, rugosae, and tibetsuensis are early bacterial colonizers or pioneers. In biofilm formation, and are the only species to have been isolated from human dental caries. Oral Veillonella cannot metabolize dietary carbohydrates themselves, and instead use short-chain organic acids produced by other species for energy. This includes lactate, which they favor as a primary substrate. A mutually beneficial relationship between Veillonella and lactic acid-producing bacteria has been proposed, where Veillonella consumes excess lactate, thereby removing metabolic end products inhibiting cellular activity and maintaining the function of acidogenic species. To highlight some relevant research, Mishima and Nakazawa showed how the relationship between Veillonella and Streptococcus species can promote biofilm formation in an in vitro experiment. They assessed 6 Veillonella species, atypica, denticariosi, dispar, parvula, rugosae, and tibetsuensis, in 24 unique partnerships with Streptococcus mutans, gordoni, sanguinis, and salivarius. The authors discovered that the presence of Veillonella increased the amount of biofilm formed in all but 5 combinations. This highlights the significance of coaggregation and metabolic cooperation in bacterial stability, success, and subsequent disease. There is evidence that suggests that Veillonella may have some predictive qualities as well. Gross et al. Recruited children at the nationwide Children's Hospital Dental Clinic in Columbus, Ohio, to participate in a longitudinal study looking at bacterial community profiles in relation to ECC. The development of dental decay was tracked during the study, and bacterial composition of dental plaque samples were analyzed over time. The authors found research on Veillonella and nutrition has focused mainly on relationships to common acid-producing bacteria. To our knowledge, no research has been conducted that directly investigated nutrition and Veillonella exposure together in relation to caries status. The purpose of this study was between caries-free and caries-affected participants. Furthermore, participants with poor nutrition and significant Veillonella present would be more likely to experience ECC than those with better nutrition and an insignificant amount of Veillonella. A case control study design was used. The study utilized data collected for another study titled Role of Taste in Oral Microbiome on Caries Risk in Young Children. The original recruitment plan sought 250 children, 125 caries-free and 125 with ECC. Under 72 months from Access Downtown, Mount Carmel Clinic, Smile Plus Children's Dental Clinic, Children's Hospital Research Institute of Manitoba, and Misericordia Health Center on days of scheduled rehabilitative dental surgery. At the time of initial recruitment, 2 plaque samples of the entire dentition were taken for 16S rRNA amplicon sequencing to evaluate microbial diversity at the main taxonomic ranks. The efficient and effective comparison of 16S rRNA gene sequence variants to established reference databases allows for bacterial classification and identification. Participants' parents or caregivers also completed a study questionnaire that covered the child's nutritional profile, feeding history, birth history, current health, oral health-related quality of life, child and parent or caregiver oral health and hygiene, family characteristics, and other demographic information. This questionnaire contained NutriStep as well, the nutrition screening tool for every preschooler and toddler, which was the primary measure of nutritional health in this study. NutriStep is a valid and reliable 17-item questionnaire given to parents or caregivers to assess their child's nutritional risk. The tool was created in Canada in close cooperation with parents, caregivers, and professionals, and is meant to be inclusive in terms of its cultural considerations and terminology. The tool is based on 4 constructs of nutritional risk for children: food and fluid intake, factors affecting food and fluid intake, physical growth, and physical activity and sedentary behavior. 12 questions widely cover the aforementioned constructs of nutritional risk, and the other 5 questions specifically focus on food group intake. This includes questions about the consumption of grain products, milk products, fruits, vegetables, and meats or alternatives. Each question has 2 to 5 response options that range in score from 0, no risk, to 4, greater risk. The scores attached to each option are weighted and reflect the level of nutritional risk associated with the specific answer. Participant responses are summed to provide an index of nutritional risk, where higher scores indicate greater risk and lower scores indicate lower risk. Total scores can range from 0 to 68. Demographic information was summarized, and additional descriptive statistics were provided for information on oral health and hygiene, feeding history, and NutriStep results. Various statistical tests were used, and a p-value of less than or equal to 0.05 was considered significant. Microbial data were provided in the form of relative abundances. This is the amount of specific taxon or group relative to the total bacteria measured in a given sample. Data were provided at the genus and species levels, and differential abundance analyses were done using the linear discriminant effect size method, which uses an algorithm to identify taxa, among other features, that characterize significant differences between biological conditions, i.e. caries status. Microbial analyses were limited to Veillonella and Streptococcus because of their relevance and prevalence in literature and to focus the study. Multivariable logistic regression was used to estimate the association of ECC risk with total NutriStep scores and relative abundance of Veillonella. Caries status was represented as 0, caries-free, or 1 ECC, and bacterial presence was represented as 0, low abundance, or 1, high abundance. The median relative abundance was used as a cutoff. NutriStep scores were included as a continuous variable. Odds ratios and 95% confidence intervals were reported. Potential confounders were assessed and included in the model if necessary, or if the difference between the crude and adjusted odds ratio was larger or equal to 10%. Age, sex, oral hygiene, place of residence, snacks per day, sweeteners, indigenous status, and newcomer status were all evaluated. In short, COVID-19 pandemic-related limitations and time constraints for the study ultimately resulted in a reduced sample of 158 children, 83 with ECC and 75 caries-free. Mean age of participants was 46.1 months, and there was almost an equal distribution of male and female participants. Age, place of residence, newcomer status, indigenous status, and parent or caregiver education differed significantly by Caries status. Children with ECC tended to be older, established residents, indigenous, live in rural or remote areas, and have less educated parents or caregivers. Approximately half of all participants, irrespective of Caries status, received government or social assistance and had a yearly household income of under $31,000 per year. All participants had seen a dentist before, and a majority had some form of dental insurance that covered all or part of their dental expenses. This included employer-sponsored plans, government programs for social service or welfare clients, and private plans. Unsurprisingly, caries-free children started cleaning their teeth at a younger age, started using toothpaste at a younger age, often brushed 2 times a day or more, and had parents or caregivers that provided more consistent help with brushing. This table summarizes participants' NutriStep questionnaire results. Total NutriStep scores, along with scores for items number 4, vegetable consumption, number 6, fast food consumption, and number 10, number of times child eats in a day, differed significantly according to Caries status. Children with ECC tended to have higher total scores and greater nutritional risk than children without ECC. Participants with ECC also ate fewer vegetables, ate more fast food, and ate too little or too much during the day in comparison to caries-free participants. On average, total scores indicated that participants exhibited only moderate nutritional risk. These are any scores in between 21 and 25 according to the tool. With regard to the other questions about participants' feeding histories, several results differed by Caries status. More parents or caregivers of children with ECC added sweeteners to their child's drinks, and children with ECC frequently enjoyed soft drinks and sweet spreads such as jams and Nutella. Children with ECC also ate significantly more snacks per day and tended to eat or drink things after brushing their teeth before bedtime. Caries-free children stopped bottle feeding at an earlier age compared to children with ECC as well. In regard to bacterial composition of dental plaque, Figure 1 is a visualization of differential bacteria ranked by effect size. These are the results of the linear discriminant analysis effect size method. At the genus level, higher relative abundance of Veillonella was observed in the ECC group, and higher relative abundance of Streptococcus was observed in the caries-free group. At the species level, Veillonella dispar and Streptococcus mutans and salivarius were significantly more abundant in children with ECC compared to children without ECC. Higher relative abundance of unclassified streptococci were seen in the caries-free group. Unclassified groupings contained bacteria that could not be classified beyond the genus level. With respect to multivariable analyses, 5 confounding variables were added to their respective models after assessing crude and adjusted odds ratios. This included age, measured in months, use of sweeteners, indigenous status, newcomer status, and snacks per day. This table provides results on associations between Caries status, NutriStep scores, and the presence of oral Veillonella after adjusting for measured confounding. Holding other covariates in the model constant, children with a high abundance of oral Veillonella examined at the genus level were 3.1 times more likely to have ECC than children with a low abundance of the bacteria. This result was accompanied by a small but significant association between greater nutritional risk and ECC. Being older was also significantly and independently associated with increased odds of experiencing ECC in this model. At the species level, children with a high abundance of Veillonella parvula were 2.3 times more likely to have ECC than children with a low abundance of the bacteria. This result was once again accompanied by a small but significant association between greater nutritional risk and ECC. Indigenous status was also significantly and independently associated with increased odds of caries risk in this model. Children with abundant Veillonella dispar were 4.2 times more likely to experience dental caries than children with a low abundance of the bacteria. However, in this particular model, higher Nutricept scores were non-significantly associated with ECC. The results of the study reinforce the fact that dental caries is a multifactorial disease. Our findings are largely consistent with the literature on sociodemographic and behavioral risk factors, some of which were discussed previously. Nutricept results supported the hypothesis of differential nutritional profiles based on caries status, as children with ECC displayed greater nutritional risk. Item-specific results were fairly consistent with previous research. Numerous studies have linked the consumption of fast food, item 6, with an increased risk of ECC. Overnutrition or undernutrition, which was item number 10, during key stages of tooth development, have also been connected to dental caries. The caries protective effect from increased vegetable consumption seen for item number 4 can be disputed, as research on the topic is mixed. Bacterial relative abundance data supported the hypothesis of differential Veillonella profiles based on caries status, as there were greater levels of Veillonella dispar in the ECC group. The pairing of Veillonella dispar with Streptococcus mutans in the ECC group entertains the proposition of the lactate-driven relationship discussed previously. Studies have placed both Veillonella and Streptococcus among the most abundant bacteria in caries-affected individuals. The inclusion of Veillonella as a positive determinant of ECC is contentious, however, as there has been very low evidence certainty regarding its role in pathogenesis. The significance of Streptococcus as a contributor to oral health can be disputed. Non-karyogenic commensal species are possibly represented in the caries-free group. Decreasing oral microbial diversity has often accompanied transitions to caries status. As ECC progresses, the oral environment facilitates the growth of karyogenic bacteria, and an overabundance of Veillonella and Streptococcus can follow. The differentially abundant bacteria in this study, Veillonella dispar, Streptococcus mutans, and Streptococcus salivarius, have been identified as important discriminatory features for ECC before in studies that have used similar methods as ours. Results from multivariable analyses conditionally support the hypothesis on the relationship between ECC, nutrition, and oral Veillonella, as children with poor nutrition or higher Nutricept scores and significant oral Veillonella present did have greater odds of ECC. Consequently, our findings propose a tentative association between Veillonella, nutrition, and dental caries, where children with abundant bacteria and greater nutritional risk may be more susceptible to ECC. Significant associations were only seen at the genus level and when examining Veillonella parvula. However, the overall significance of Veillonella parvula and dispar is not undermined by their respective absences in the comparative test. Our findings reflect the importance of both bacteria for ECC instead. For this study, Veillonella dispar constituted a better characterization of disease status in measurement of quantity, and Veillonella parvula provided a better indication of bacterial effect in conjunction with morbidity, nutritional risk, and other factors. While it is comparable to other good microbiome studies, the restricted sample is a limitation of this study. The sample may also not have been representative of children living in Winnipeg and Manitoba at large. Similarities in participant characteristics and health-seeking behaviors for families visiting participating dental clinics leave open the possibility of sampling bias. It is important to note that we limited our evaluation of nutritional status to Nutri-Step, which is susceptible to recall bias and is a simplified assessment of nutritional health. In most cases, it would not be appropriate to extrapolate these results to other nutritional considerations. Microbial analyses for this study also has its limits. There is limited depth in 16S rRNA amplicon sequencing, and greater information on things like the functional microbiome and bacterial strains could have provided greater insight. Moreover, the decision to limit microbial analyses to Veillonella and Streptococcus forces the study to take on a more reductive and descriptive role, and ignores the complexity of interactions between microorganisms that cause a disease state. The inability to delineate the specific role of unclassified bacterial groupings is also a weakness of the study. These bacteria formed a relatively unexplainable conglomerate and were examined as such. A strength of this study is that it functions as a novel and preliminary examination of nutrition and oral Veillonella in the context of ECC. This study provides the foundation for more comprehensive research on Veillonella. Research, including metagenomic and mechanistic studies, are needed to characterize the causative role of Veillonella in ECC, as the relevance of this bacteria in etiological discussions is largely understated. This study highlights the importance and interdependence of biological, behavioral, and social factors in health and disease, and is beneficial in that it promotes a more complete view of the disease process. I would like to quickly thank my advisory committee members, Dr. Robert Schroth, Dr. Prashen Chelikani, and Dr. Nathan Nickel for their expertise and guidance during this study. I would also like to thank Dr. Vivianne Cruz de Jesus for her work and knowledge on the biological data, and Betty-Ann Mittermuller for organizing much of the initial study. I would also like to express gratitude to the rest of the study team for their work, and would like to thank the clinics and institutions that allowed the initial recruitment of participants at their sites. This research was supported by a University of Manitoba graduate fellowship as well. And that concludes my presentation. Thanks everyone for listening, and I will hand it over to Daniela.
Remind everybody that if you do have questions for Victor, type them into the chat or wait until after Vivianne does her presentation, and then we will have some oral questions if we have time. But please type it into the chat and then we'll get to it. All right, Vivianne, if you want to begin with yours.
Oh, yeah, sorry.
Good afternoon, everyone. Second here. Okay, so today I'll be presenting about our recent study on the effects of silver diamine fluoride on the oral bacteriome and microbiome, which are the bacterial and fungal communities found in our mouth. And first of all, I would like to acknowledge our research team, especially Dr. Mayura, who led the study, and this was her master's thesis for her master's in pediatric dentistry. I also would like to acknowledge that the University of Manitoba campuses are located in original lands of Anishinaabe, Cree, Oji-Cree, Dakota, and Dene peoples, and on the homeland of the Métis Nation. We respect the treaties that were made on these territories. We acknowledge the harms and mistakes of the past, and we dedicate ourselves to move forward in partnership with the Indigenous communities in a spirit of reconciliation and collaboration. I will briefly discuss the background of this research, and starting with dental caries or tooth decay. Victor has already explained how the tooth decay develops, and I just want to remind that caries is a multifactorial disease, which means that it is caused by a combination of factors, including the increased levels of caries-causing bacteria, the presence of decreased microbial diversity, which is the the number of different species in the oral microbiome. The presence of teeth that are susceptible due to enamel defects and the frequent consumption of sugar. Here in this figure, we highlight that the initial stages of caries is characterized by these white spot lesions that, if left untreated, they progress to the cavitated caries lesions or cavities, and they both require treatment. We know that the oral microbiome is very important for the oral health. There are studies showing that a healthy microbiome is associated with a healthy mouth. And there are also studies showing that an unbalanced microbiome is associated with oral and systemic diseases. However, most of the studies looking at those associations focus on bacteria. And we know that the oral microbiome is composed of more than bacteria, and specifically the fungi. There are recent studies showing that the fungus Candida albicans can work together with Streptococcus mutans to cause tooth decay development. And therefore, this suggests that it is important to study not only bacteria, but also fungi. Talking about the Silver Diamine Fluoride, also known as SDF, this is a simple and non-invasive topical fluoride solution that is used to arrest caries in children. A solution of 38% SDF contains about 25% of silver, 5% of fluoride, 8% of ammonia, and 62% of water. And SDF is used to stop cavities from getting worse, and the solution helps to keep the teeth healthy. We know that the treatment of caries in young children can often require high-cost general anesthesia treatment, and that this may not be available and may not be affordable to all populations. Therefore, it is important to have options for treatment that are more affordable and available to everyone. And we know that the application of SDF in young children that they're still not able to tolerate the restorative procedures can stabilize the caries lesions until the child is old enough to cooperate for traditional restorative techniques. However, there is currently no consensus on the frequency of application of SDF for optimal arrest rate. Therefore, it is important to study which application of SDF, which frequency of application of SDF is the most effective, and what effects SDF have on the oral microbiome in order to optimize the implementation of this treatment. Therefore, the objectives of this study was to determine the arrest rates after SDF applications in 3 different frequency regimens, and to determine the potential changes in the oral bacterial and fungal communities that result from SDF applications in 3 different frequency regimens. Moving on to the design of the study, this was part of a larger randomized control trial that was done to investigate the effectiveness of using SDF to arrest caries in young children here in Manitoba. And a subset of 45 children that were younger than 72 months of age, fitting the criteria for early childhood caries, they were recruited here at the Children's Hospital Research Institute of Manitoba, or at local community-based dental clinics. The inclusion criteria for this study included child that is younger than 72 months of age with ECC, and that had soft cavitated caries lesions extending into the dentin. The child also had to have at least 1 primary tooth with caries that is eligible and allows for the direct application of SDF. The exclusion criteria included allergy to silver, generalized developmental defects of enamel, severe medical problems, a child that requires immediate rehabilitation under GA, and antibiotic use within the last 2 weeks, because antibiotic treatment can affect the oral microbiome, and teeth with pulpal involvement. Here we describe the 3 regimens that were studied in this research. So the regimen 1, or what we call the regimen 4M, was done with 15 children that were randomly selected for or divided into the 3 regimen groups. In the regimen 1, they received 2 applications of SGF 4 months apart. In the regimen 2, they received 2 applications 6 months apart. And on the regimen 3, or 1M, they received 2 applications of SGF 1 month apart. The children were seen at 3 different visits. Visit 1 was the baseline, where we collected questionnaire information, as well as we did a dental assessment, and we collected supragingival plaque samples by scrubbing an interdental brush in the child's teeth in all available tooth surfaces. And we started the first application of SGF, which was followed by, according to the different regimens, with different time points, we had a follow-up visit with, again, dental plaque collection and a second application of SGF. During those visits, we also assessed the carious lesions based on the clinical hardness, the color change, and the size of the lesions. And we also recorded the GMFT score, which is the sum of the number of decayed, missing due to caries, and filled teeth. I would like to highlight that the regimen 1 was based on the Winnipeg Regional Health Authority Oral Health Program protocol. The regimen 2 was based on the protocol suggested by the American Dental Association, and the regimen 3 was based on the protocol proposed in the American Academy of Pediatric Dentistry Clinical Practice Guidelines. The dental plaque samples were used to extract the microbial DNA in order to sequence the DNA of bacteria and fungi, and that allowed us to identify the species of bacteria and fungi that were present in the children's teeth before and after the treatment with SGF. Moving on to the results, here we have the characteristics of the study participants. So the average age of the participants was 43 months, and we had a higher proportion of males than females. The study groups were randomly assigned, so we didn't have equal number of males and females in each group. Looking at the average arrest rates and GMFT score, what we observed was that the average GMFT score for regimen 1M and 4M remained stable throughout the study. However, for regimen 6M, there was an increase in the GMFT score. There was a total of 195 caries lesions that were assessed and treated with SGF, in a total of 44 children that were treated. We lost 1 child for follow-up, so that child was excluded from the study. When we looked at the average arrest rate at visit 2 and 3, so after the first application, the second applications of SGF, what we observed was that for all 3 groups, there was an increase in arrest rate after the second application of SGF. And the regimen 4M was the one that showed the highest arrest rate. We also observed that the regimen 6M showed lower arrest rates and increased GMFT between visits 1 and visits 2 and 3. And this could be because the effectiveness of the lesion arrest by SGF could decrease over time. So our conclusion for this part of the study was that 6 months between applications may not be optimal for arrest of caries in high-risk children. Moving on now to the results for the microbiome, starting with bacteria. As I mentioned, there was one child that was lost for follow-up. So the 3 samples from the 3 visits for that child was excluded from the microbiome data analysis. And we started looking at the alpha diversity, which tell us how many different species of bacteria are in each of those groups. And here we are comparing visits 1, 2, and 3 within the 3 different regimens. So what we observed here was that there was no statistically significant differences in diversity in any of the 3 groups. However, we did see in regimen 4M a trend of increased average diversity between the 3, from comparing visit 1 to visit 3. And this is interesting because there are studies in the literature showing that increased diversity is associated with a healthier microbiome. We also looked at the relative abundance of the most abundant bacteria in the dental plaque samples. So here we have the proportion of those species divided by the 3 visits and the 3 groups. There were significant differences in the relative abundance of many species of bacteria, including those that have been associated with dental caries, such as lactobacillus and bifidobacterium, that were decreased in abundance after the 2 applications of SDF. I also highlighted here the abundance of Streptococcus mutans, which is known to cause tooth decay. We observed that at visit 3, there is a decreased abundance of Streptococcus mutans compared to visits 2 and 3 and 1 in all 3 groups. However, this was not found to be statistically significant. Moving on to the fungi, we looked at the diversity as well in the fungal communities, and we observed that there was no significant differences in microbial diversity between the groups. We also looked at the proportion of the most abundant fungi in the dental plaque of the children, and we observed that Candida albicans, represented here in pink, was the most abundant species in all groups. However, there were a few species of Candida that were more or less abundant in some of those groups. So this was analyzed using the differential abundance analysis. And here we can see that there were multiple species that were either more abundant or less abundant in visits 1 and 2, visits 1 and 3, and visits 2 and 3 in all the regimens. Highlighting again that Candida tropicalis was more abundant in the visits 1 compared to visits 2 and 3. So in this study, it was interesting to note that we did not see any statistically significant loss of diversity following the SDF treatment. And this is important because as I mentioned before, increased diversity has been associated with healthier microbiome and a healthier oral cavity, right? So we don't want to see a decrease in diversity. And this supports the findings of a previous study that showed that the use of SDF is safe with minimal risks of growth of opportunistic infection. So the overall bacteriome and microbiome composition remained stable over time. Our study also found a vast diversity of fungal species. So until recently, when the studies were based on culture, trying to grow the fungi in the lab, they were not able to identify too many species in the oral cavity. So there was a large focus on Candida albicans. However, after the development of more advanced techniques with DNA sequencing, now the studies are showing that the oral microbiome, the fungal communities in the oral cavity, is very diverse. And this agrees with our study that found that there were hundreds of species of fungi in the dental plaque of the young children. We also found inhibitory effect of SDF in the oral fungal community. In our study, we noted the decreased abundance of Candida tropicalis at visit 3 compared to visit 1 and 2. And SDF has been shown to have antifungal effects against some of the Candida species, including Candida tropicalis. So it is important to study these species of Candida and try to identify what is the role of Candida tropicalis in dental caries development. This study was the first one to look at the effect of SDF in not only the bacterium, but also on the microbiome after the treatment at 2 different visits in young children. However, it's not free of limitations. Most of the oral fungi that are present in the mouth, they have low biomass and may be difficult to detect in oral samples. So even though we were able to detect many different species of fungi, there is still some fungal species that have been found in other studies that we were not able to identify here. Also, the sample size may explain why we were able to see some clear trends, but not statistically significant changes in diversity. So the conclusion of this study is that SDF was an effective modality for arresting caries with higher rates of caries arrest after 2 applications. And taken together, our results suggest that SDF treatment may have an effect on the abundance of specific bacterial and fungal species, but it does not modify the overall microbial structure of the supragingival plaque. And that future studies with larger sample size are needed to confirm if the microbial changes are the result of the SDF application at various frequencies. And I would like to highlight the clinical implications of this study. We know that SDF is an effective strategy for treating ECC and may have a significant role in shifting the model of using surgical interventions to disease management, particularly for high-risk groups who face challenges in obtaining the conventional care. Findings from this study also suggest that 2 applications of SDF is more effective than 1 application, and children must be reassessed at regular intervals. However, the choice of treatment protocol may vary according to the patient risk level. I would like to acknowledge all the team members that collaborated for the development of this research. And I would like to thank the participants and the community-based dental clinics in Winnipeg that allowed us to recruit patients and do the treatment. And as well as I would like to thank the Children's Hospital Research Institute of Manitoba for funding and the Dr. Gerald Nisnik College of Dentistry Endowment Fund. And thank you all for attending our presentation today.